attendees, you may stand up from your seat. All right, you may now sit. We will now hear a few words from our Vice Dean, Dr. Sri Susilawati. Doctors and participants, please welcome Dr. Sri Susilawati.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. The distinguished Vice Dean, Dr. Endang Samsudin, Professor Suharjo, all of the managers, head of departments, head of study programs, head of international office, Dr. Zakia, Dr. Yolanda, Dr. Ibu Nasmi, and team, all professor, doctors, our students, also ladies and gentlemen. Good afternoon, Professor, Madam. It's my pleasure to welcome each and every one of you to our faculty. Today, we are gathered here for a special occasion, a guest lecture in the area of dentomaxillofacial radiology. First and foremost, I would like to extend a warm welcome to our distinguished guest speaker, Professor Ji Yang from Temple University, USA. We are truly privileged to have such an accomplished individual share their expertise and experiences with us. The opportunity to host this guest lectures aligns perfectly with our mission to provide a comprehensive and holistic education to our students, faculty, and staff. Today's guest lectures focus on fundamentals of CBCT and Sinus interpretations. Cone beam compute tomography is a spatial imaging technique that provides a 3D image of dentomaxillofacial regions. It allows us to evaluate the sinus through its anatomy, structures, pathology, air fluid levels, and many more. Overall, CBCT plays a significant role in the interpretation of sinus conditions. It is important for dentists to learn more of this aspect. Prof. Jiang has an impressive background in this field. I have no doubt that this lecture will leave you updated with valuable knowledge. Before we commence, I would like to express my gratitude to everyone involved in organizing this event, the faculty, staff, and upgraders who have dedicated their time and efforts to make this lecture possible. Once again, I extend, on behalf of my dean, I extend a warm welcome to Professor Jiang. We are thrilled to have you here today. And to our students in auditorium room and in Zoom meeting, I encourage you to approach this lecture actively and seize this chance to engage with our guest speaker. Thank you, and let the lectures begin. Bismillahirrahmanirrahim. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dean Susie, for your very nice.
Thank you for your kind and encouraging words, Dr. Sri Susilawati. Without further ado, let's start the main agenda. The main agenda would be a lecture from Professor Dr. J. Yang entitled Fundamentals of CBCT and Sinus Interpretations with Dr. Anggun Rafisa as the moderator. Dr. Anggun Rafisa completed her dentistry preclinical and clinical study in Universitas Pajajaran. She then continued to get her master's degree in public health at Universitas Pajajaran and graduated in 2016. She is currently an assistant professor of oral biology department at Faculty of Dentistry, Universitas Pajajaran. She has published several articles, with the most recent ones focusing on salivary calcium level in hypertensive female patients and nutritional status in children with ECC in 2022. She has also published several books, participated in community services, and been involved in several projects in 2022. Without further ado, everyone, please welcome Dr. Anggun Rafisa.
Thank you, Nadine, for the kind introduction, and good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Okay. First of all, I would like to thank our Dean, Dr. Dudi Arifin, our Vice Deans, Dr. Susi Susilawati, Dr. Endang Samsudin, and the organizers, the International Unit, for the great opportunity. I'm truly honored for hosting today's lecture. And to all the participants, esteemed faculty members, and also the students, whether you are here with us in this room today, joining us via Zoom, or streaming this lecture live on YouTube, I would like to express our sincere gratitude for your presence and engagement. Your commitment to learning and your active participation are truly commendable. And today we are privileged to have with us a renowned expert in the field of dentistry, Professor Dr. Ji Yang, Doctor of Medicine in Dentistry, Master of Science from Temple University, Philadelphia, United States of America, who will be enlightening us on the topic of fundamentals of CBCT and sinus interpretation. We are indeed fortunate to have him share his invaluable insights with us today. And before we begin, let me give you a brief introduction to Professor Dr. Yang' illustrious career. Okay, Professor Dr. Ji Yang is a professor and director of oral and maxillofacial radiology at Temple University, Kornberg School of Dentistry, USA. Currently, he serves as director of American Board of Oral and Maxillofacial Radiology. Dr. Yang was past president of International Association of Dentomaxillofacial Radiology. He was also past president of American Academy of Oral and Maxillofacial Radiology. Dr. Yang has published numerous articles and research abstracts in the field of dental and medical imaging. He has been serving on editorial boards of many prestigious journals. He has supervised many international visiting scholars and presented lectures worldwide. And ladies and gentlemen, before we dive into the presentation by our esteemed speaker, I would like to inform you that following the speaker presentation, we will have a 15-minute discussion session. This is an excellent opportunity for you to engage with our speaker directly and seek clarification on any points you may have. Okay, without further ado, ladies and gentlemen, please join me in giving a warm round of applause to welcome our honorable speaker, Professor Dr. Ji Yang. Okay, thank you, Professor, and you may start your lecture. Thank you.
Thank you very much for your nice introduction. And thank you, the Dean Susie, Dean Vice Dean, and also the Martin, the head of the international affairs. And also thank you, my the friends, Professor Suharjo Sitam, and also the Dr. Lucy and the dear faculty, students. It is my great honor to be here in this great university. This is actually my second time with the university, and so this is really the privilege to be here. Now, this morning I talked in the Congress talking about the future that the dental imaging, but I was told that many of you are dental students, so I would like to share some more fundamentals of imaging, like combined CT imaging, and also share some information about the sinus the imaging, because when we're doing the dental implants, we often dealing with the maxillary sinuses. Okay, this is my school, and I'm coming from the Temple University, which is located in Philadelphia. Some of you may be there, some maybe not. The university is like in Philly. Philly is like the first capital of the United States, and yeah. Oh, really? I already share screen. And can we share the screen?
Ladies and gentlemen, we apologize for the technical difficulties that we are having now. Please wait for the lecture to start, and thank you. Perhaps I could try from here. You may proceed.
Okay, great. Yeah, thank you. Again, now the title for my presentation is Fundamentals of CBCT and Sinus Interpretation. So I hope this could help with the dental students to understand the CBCT and also the sinus interpretation. Let's see.
Okay.
Yes. Okay. So my university is in Philadelphia. Is the one of the probably it's like a fourth, fifth largest city in the United States, more like Bandung. Yeah, yeah. So it was the first capital city in the United States. This is my school, Temple University. That the hospital and the main campus. And also before the pandemic, we honored host the 22nd International Congress, Dental Maxillofacial Radiology Congress. We had more than 600 dental maxillofacial radiologists worldwide in the city, including the Professor Suharjo Setam was there. Now, as we know that the dental maxillofacial imaging, right now we have still used the intraoral and extraoral radiograph. Now, intraoral, we have the Bite-Wins periapical radiograph. Extraoral, we use panoramic radiograph and the saprophometric radiography. But over past 15 years, 20 years, the 3D convex CT has been widely used in dental practice. I was told that now in Indonesia, many in school or even the practitioner also use the convex CT in the treatment planning now. So this is a great the progress in dental maxillofacial imaging. Now today we're going to talk about the 3 items. One is the basic concept of and application of 3D CBCT. And the other will be focus on the findings of the sinuses, some anatomy or variation of anatomy and the pathology, particularly if the students involved into the sinus lift, and we would need to know the osteometer complex, the sinus anatomy as well. So finally, I will talk a little bit about radiation dose and the safety concern. Although right now not too many people are using the combined CT, but in the United States, we have so many combined CT units. In this morning's meeting, I was mentioned that in US, the 1 year, the whole country, there were 4,800 combined CT machines were sold to the dentists. So you can imagine how many combined CTs in US. So that's why we need to know a little bit about radiation dose and the safety concern. So basic concept, the combined CT, I know that you have the CT unit in the building, and certainly you would have some experience in the combined CT. But the combined CT, the principle is similar to panoramic imaging. You can sit or standing so that the patients can located between the source of radiation and the detector. And usually the source of radiation or detector rotating 270 to 360 along the patient's head. Now, during that rotation, you will get 150 to 600 raw imaging data along patient's head. Then those raw image data will be transferred into the computer. The computer then can do the processing and generate a three-dimensional data set. So that's why we got 3D the imaging from the combine. The reason these days the price is going down, one is because the imaging price, the computer price is going down. The other, the flat panel detector price is going down. So worldwide, there are about 100 different combined CT machines now. So prices are much more affordable these days. Now with the 3D the data, so we can generate a different the section, different the plane. We can have this axial view, coronal view, and the sagittal view, and also we can generate the surface reconstruction. Now, most importantly for us, if we do the dental implants, cross-sectional view is the most helpful. So you can select the tooth location, then do the cross-section, and you can get the bone height, bone width, and the inclination of the bone. Now, when compared to medical CT, because medical CT is much longer than the combined CT or dental CT, but the dental CT or combined CT has some the good feature when compared to medical CT. The voxels created on CBCT are isotropic. That means that all the dimensional direction, they have the same or equal the distance with that voxels. In medical CT, voxels is anisotropic. It's not the same in all the direction. So the uniform voxels meaning the CBCT has a superior dimensional accuracy in reconstruction process of raw data. So this is good for the dental implants because we need to do those measurements with the combined CT. Now, how does the CBCT benefit to our practice, and what are applications? So most of you know that we use this for implants, but as maxillofacial, dental maxillofacial radiologists, we find that this is also very helpful for the diagnosis. For example, this is a patient with the orthodontic surgery. But the patients after 2 years feel discomfort in the left side of the maxilla. If you, I know there's some, if the right stance, radiology right stance here, you can look at the pen and see if there's anything abnormal in the maxillary left side of the maxilla. So actually we, after a look at the carefully, we still cannot see any abnormality in the left side of maxilla. So we recommend for a combine CT. Now with the combine CT, this is it's very easy to recognize that in the left side of maxilla, there's a cyst like a lesion and there, which turned out to be a surgical ciliated cyst of maxilla. Now this kind of cyst is it's post-surgical change. When the patient had the orthodontic surgery, some of the oral mucosal membrane was embedded inside the bone, so that the membrane later on developed into a cystic lesion, which is called the surgical ciliated cyst of the maxilla. So that's the 3D. It's better than 2D in diagnosis of the cystic lesion in the maxilla. Now, this is another case, and if you look at this panoramic radiograph, the chief complaint of this patient is the pain in the right side of the maxilla. So with this panoramic radiograph, do you see any like abnormality? If the radiology, if you have experience in the radiology right stance? Yeah, that if we quickly look at the pen, sometimes it's hard to see the change. We can see here if we look at the border of the maxillary sinus, left side is intact. The right side that depends on light. If it's with this kind of light, maybe it's hard for you to see any the change. And also that there's no caries lesion, and the bone level, only thing like this portion of the third molar is kind of the resorbed in the distal. But if we do the CT, and we can see this is easy to recognize the pathology. You can see there's the there's the opacity, the mucosal, the thickening, and in the maxillary sinus. And yeah, and also, but the mucosal thickening, like my right stance was they're saying, oh, we see all the time. If you do the implants, a lot of patients have like a mucosal thickening. But this patient, it's different. You can see there's the bone destruction in the posterior aspect of the maxillary sinus. So this is not traditionally we see that the sinus inflammation or sinus sinusitis. And most importantly, I think I'm not sure if I can use the point here. Yeah, it's not the. Yeah, the sometimes that you can see that the medial pterygoid plate, lateral pterygoid plate. I can, some of you maybe know that the anatomy, the lateral pterygoid plate. Let me just, okay, I probably cannot. Then the people in the Zoom, the lateral pterygoid and the medial. Do you have the mouse? Oh, okay. Wonderful. Yeah, Wonderful. Yeah, that's very good. This is a lateral pterygoid plate of sphenoid bone, all right? This is the medial pterygoid plate of the sphenoid bone on the left side. But if you look at here, that's the lateral pterygoid plate of the sphenoid bone. But the medial pterygoid plate was destroyed or partially destroyed. And there is certainly you can you probably can see there's a sort of like soft tissue mass here. So this is not the typical sinus inflammation. And this turned out to be a squamous cell carcinoma. Yeah, so that's the point here is that the 3D combing CT is more useful for the diagnosis of the pathology in the dental maxillofacial region. So if we're going back looking at here, so this is a if the light is good, this you see sort of like permissive the change. You see some of the small tiny radiolucency there, and also the sinus border is not continuous as the left side. So that's the one of the sign, and the other side there's certainly like pronounced vertical bone loss, the distal to the third molar. But that part sometimes it's hard to say because there's looks like the tooth is super erupted. There may be the early contact, so that's kind of causing the bone loss. But the permissive change in the sinus floor, that's the sign indicate some sort of neoplastic lesion in nature. But again, if we are busy in the clinic, we probably on the pen we can miss this kind of the pathosis. But with the combing or medical CT, we should be able to recognize that kind of lesion. So that's the combing CT can help our diagnosis. For dental implants, that's certainly this is actually the driven force. We have the CT or combing CT in dentistry. We can look at the bone quantity, quality. We can look at the shape, anatomy, and also if we do the bone graft sinus lifting, that's really helpful for us. Nowadays, if we need a full mouth reconstruction, and we can do the virtual implant placement, and we also can use the template for guided surgery that some the study is going on with the guided surgery. Now this is just shows like if you use the panoramic view, if like look at here, if you just look at the panoramic view, you can see the bone height there, but you probably don't see the bone width. You know, like there's some like sort of like depression in the anterior aspect of the mandible. Now with this kind of change, without the combing, it's hard to see this kind of change. In the old days, when people place dental implants there, you see a lot of lingual perforation because of not seeing this kind of concavity there inside the mandible. Yeah, this is the patients with the implant placement outside the dental office. But the patients feels discomfort after the implant was placed. By looking at the panoramic radiograph, that looks not bad. Actually, the implant looks like the right in the sinus area. But if we look at the cone beam, we take cone beam, we see that there's the buccal, the perforation of the implants. That's the reason why the patient's discomfort after implant placement. Now, this is another the failure of the dental implants. This is probably you all know that this is also it's a kind of unfortunate patients that she had the implants the outside. The dentist also use panoramic only to place the implants. Sometimes the panoramic radiograph cannot see the mandibular nerve canal well. So this one that turned out to be with the perforation of the mandibular foramen. So that's the reason has the patients got the permanent numb of the lip. So sometimes if we place the implant in the anterior of mandible, we also need to be careful because that the lingual foramen is here. The lingual foramen is the terminal branch of the mandibular canal. Because mandibular nerve, they come in from the mandibular foramen, then goes to the mental foramen. The main branches come out. All right, that's the mental nerve. But the nerve with mandibular nerve still go anteriorly to innervate anterior teeth. The terminal branch is coming out from this the foramen. That's the lingual foramen. Sometimes lingual foramen is small. Sometimes the lingual foramen is big. If it's the big, when you place implant right on it, you may damage the artery in that canal. So that's the bleeding. The bleeding will go through the floor of the mouth and causing the swelling of the floor of the mouth. And a severe one can cause in that the narrowing the airway, and the patient can die of this kind of the placement. And years back, there was publication, the case a report from the Hawaii that one of the patients died 1 day after implant. That's because that implants located in the lingual foramen, lingual nerve. So that's why that with the three-dimensional view, it's good for the implant placement. Now, for the sinus lifting, so certainly that the CBCT can give you more information. You can know that how much bone you need for the dental implants. So this one can boost your confidence. And the virtual placement of the implants these days, you can do full mouth reconstruction. Some people can finish the full mouth reconstruction with the 1 day or even the 1 hour with the virtual implant placement. And some the dentists, they place the implant into the zygomatic bone or pterygoid bone, because if there is a severe atrophy of the alveolar process, so you can have the implant deep into the patient's face to the zygomatic bone. So you can imagine with this kind of surgery, you must need combing CT. You cannot just use the panoramic radiograph. So some study also used the navigation. They're testing the navigation system that see if like GPS for the driving. This is the company come to our school to test it, but sometimes some people say, well, it's still a little bit too risky. And the wonderful recommendation is that if you use the navigation software, the best way to do it is use the robot, because it's used that your hand is maybe shaking. The robot is kind of stable. They can, you tell them like 1 millimeter, 2 millimeters, they can do more accurately. So that's for implants. For endodontic, the treatment planning, that's also very useful. We see that the endo lesion from the periapical radiograph, but some the periapical the endo lesion, we may not be able to see that in the periapical radiograph. For example, this case that in the root superimposed over the zygomatic process of maxilla, and you don't see that the apical lesion, but with the cone beam, you can see this the lesion clearly. This is an apical lesion there. And this is another case you cannot see, and but with the cone beam you can see the apical lesion. Now, based on the literature, with the cone beam CT, you can see that more apical lesion, endo lesion, like 34% more the endo lesion than the intraoral radiograph. So also for endo lesion, sometimes we have the vertical root fracture. Vertical root fracture sometimes is very difficult to diagnose in the clinical situation, particularly if the orientation is medial distal orientation like this one. The intraoral radiograph, you may have the hard time to see that the vertical root fracture. But with the cone beam, you can easily see that the fracture is here, and this is a medial distal root fracture here. And also the root fracture tends to be in the area like the post and the core, in the post the core area. That's the area you often see that the root fracture there. TMJ assessment, cone beam also is very helpful for the temporomandibular joint diseases. And some people were saying that this may be the trabecular bone pattern described in the cone beam CT, maybe better than medical CT. So that's why you can see that there's the cortical bone erosion on the cone beam CT. And also you can easily recognize that what is the normal look like. This is a normal condyle with the thin corticated border along the condyle. And you can see a little bit of sclerotic change in the superior aspect of the condyle, sclerosis of the condyle. You can see the flattening of the condyle. And the flattening can be the superior, inferior. You also can see flattening anterior and posteriorly. So that's you can see on the cone beam. And the cortical erosion, you can see that the loss of the cortex, that also you can see the from cone beam. Anterior osteophyte formation, you can see here. That sometimes you also can see subconjugal cyst formation like this one. Now, for all the medicine, sometimes if the patients with the present with the temporomandibular joint the disease, the cone beam certainly can help you to assess the bone change. Now, this is degenerative osteoarthritis. You can see that the flattening and the sclerotic change, and with the anterior osteophyte formation. Now, for orthodontic treatment planning, that the cone beam also is helpful. A lot of time we do that. This impact the canine. You need to know if it's affecting the adjacent lateral incisor or first premolar. So this one, like this one, has the significant resorption of the adjacent tooth. That so this is with the cone beam we can see that the impacted the canine impacted tooth in the jaw. And this is patient with the cleft palate. So certainly the cone beam can see that like how much bone loss and helping you to do the orthodontic treatment planning. Now, these days, sleep apnea is it's become, particularly in United States, a lot of sleep apnea patients. So not only physician involved, some the dentists also involving to provide treatment for sleep apnea patients. We can, some prosthodontists, they fabricate some device to pull the tongue out of patient's mouth and help him with the patients with the sleep apnea. And we can use cone beam to assess the sinuses, airway, this one. We can do the segmentation of the pharynx, the air space. This is the segmentation of the air space. And also based on the study, this is from the CT, the study, the obstructive sleep apnea patients versus normal control patients. You can see that the volume, the sleep apnea patient's volume, air volume is reduced. The smallest air, it's a smaller than control. Now this one actually that the people use the most often, smallest air. If this is kind of small, it's narrow, usually it's indicate some sort of sleep apnea. But now combined CT, we cannot provide a definite diagnosis for obstructive sleep apnea. The reason is that when we take combine, we kind of like standing or sitting, not really in the sleep condition. So that's we still rely on the medical diagnosis. But some of the dimension can help us to do the assessment of where is the narrowing of the airway. And that's the difference between the normal and sleep apnea. Like this one, you see there's the narrowing, potential narrowing here. Although we cannot say this patient have that sleep apnea definitely, but there's the indication is the possible the sleep apnea. And also we do that the measurement, we can use the software. Many software can do the measurement now. Like this one, this is used Anatomage in vivo software, which is from the United States. And we can see that the minimum air is here, right between the soft part and the pharynx, the soft tissue. So minimum air is 34 millimeter square here. And also the one thing with the combine, you can see there is enlarged cellatosica. You know, this is like 20 millimeter. Certainly it's much bigger. Normally it's about like 10 to the 12 millimeter. Some maybe can as big as to the 15 millimeter, but this certainly is not the 20. And also this is the border is not as smooth. This is kind of like looks like some like a depression here. So this is a patient with the pituitary the tumor inside the cellatosica. Then those kind of patients, sometimes if there is the hormone produced that can cause in the gigantism or there's some that also narrow in that airway. Impacted third molar, certainly we can use the combine to see the mandibular nerve, see how close to the impacted third molar. That's also useful. For the surgeons, sometimes use that looking at the condyle in different stage. We call the 4D imaging, different time overlapping, and also we can do the lesion. If there's like this, there's the large lesion in right side of the mandible, and we can use that these days the 3D. We take the combine, we use the 3D printout the model, and we can do the pre-surgical the dissection and also fixation. So this can save a lot of time when we do the actual surgery. So that's pretty much the application of the combine CT these days we can do. Now for the sinuses, because when we do the combine, a lot of time we're looking at the sinuses. For maxillary, the implant that often we need to do the sinus lift as well. As we know that we have 4 paranasal sinuses: maxillary, front, ethmoid, and the sphenoid. When the sinus, when patients is young or just born, it's like a small the sinus 1 to 2 millimeters cube in newborn. It completed at age 12. So when that 12 years or older, then the sinus is kind of mature. There are two phase, fast development phase. 0 to 6, when the newborn to 6 years old, the sinus most likely develop horizontally. But from the 7 to 12 years of age, the sinus mainly develop vertically. I don't know if you have experience, maybe your child, your friends, you see that when they are small, the face is kind of wide. When they grown up, why the face is kind of longer now? That's because of the sinus. And actually, our younger daughter was like that. And when she was young, she was like the face is wide, and now it's more vertical. That's because the development of sinus. There are two phases. When this is the first 2 to 3 years of age, that's the small, like 7 to 8 years of age is to get this point. And when they mature, the sinus floor usually is below the floor of the nose or hard part. So that's the normal. You have like kind of like a normal, the below the floor of the nose. Now, to know the sinus, normal sinus has a lot of clinical implication. The one of thing, for example, like this is a right side, this is a normal, and we have that this bony structure which is called uncinate process here, between the nasal cavity and the sinus. And a lot of time, ENT or head and neck surgeons, they open up this uncinate process to clean up the sinuses. If there's a lot of infection in the sinuses, we need to open up the sinus drain. So by breaking the uncinate process. But on the left side, this is a kind of a variation of anatomy. The sinus hyperplastic, hyperplasia of the maxillary sinus. And with this kind of opacification, and the uncinate process was kind of pulled along with the sinus to this area. So if the surgeons did not recognize this problem, they just open up the bony structure. The first bony structure is not uncinate process. This become the orbit. So that's certainly if they break the orbit, the consequence is significant. So that's do we have to? We can continue, or we can continue. Okay. So that's this is the floor of the orbit. We need to recognize this anatomy. Also, there's some other anatomy. Since we're dealing with the paranasal sinuses, we also need to know that there's a pneumatization of the anterior clinoid process, and this is a part of the sphenoid sinuses, and the optic nerve sometimes also can close to or adjacent to the sphenoid sinuses. So this is when people doing the sinus surgery, usually, fortunately, dentists, we don't go up to the sphenoid sinuses. Usually it's the ENT head and neck surgeons they do. Then they have to recognize this variation of anatomy. Also the cavernous sinus, which is next to that, this is next to that the sphenoid sinus. We can see the cranial nerve from 3 to 6. This is the cranial nerve, we can see here, cranial nerve to 6. Now, one thing in the cavernous sinus we need to know, recognize on the cone beam, it's the carotid artery. The carotid artery also goes through that cavernous sinus, and normally it's fine, but sometimes the artery can be calcified, like this one. This is a carotid calcification in the skull base. You know, some of you have experienced taking pen. You see the carotid calcification in the neck, but actually we can see much more often in the skull base carotid calcification. So when you're looking at the cone beam CT, particularly in radiology, the residents, when you do the interpretation, you need to pay attention to the skull base, make sure the patients have no carotid calcification there. Now, this is just a normal anatomy, like a Vidian canal or pterygoid canal. Now, some of the variation of normal anatomy, when we do the implants, sometimes we'll pay attention to it. Here is the concho brosa. Concho brosa is like a pneumatization of middle concha. Normally, it's fine. Patients have no symptom, but sometimes if this pneumatization is big enough, they may narrow in the osteomiatal complex. And sometimes patients have like deviated nasal septum. Patients also may have the symptom due to the deviated nasal septum. Now, osteomiatal complex, this is a very important anatomy. People doing the implants, looking at the sinuses, they always make sure that the osteomiatal complex is patent. Now, osteomiatal complex, you can looking at from here. This is the ostium, that's the opening of the maxillary sinus. Then you go in the further. This is the infundibulum of the ethmoid bone, and the medial to the infundibulum, you can see that the bony structure we talk about. It's the uncinate process, and here is the next one is that the semilunar hiatus, that's the opening between the sinus to the middle meatus. So that's the middle meatus. Now here's the ethmoid bulla. It's the part of the ethmoid sinuses, and also you can see the frontal recess. The frontal recess is the draining from the frontal sinuses. So all these from the maxillary sinus to the or from the ethmoid sinus and also frontal sinuses. This is we call the anterior common drain pathway. So this is a area people sometimes they call this the anterior like osteomiatal complex in the anterior region. Now for posterior, like posterior ethmoid sinuses and the sphenoid sinuses, they would drain through the, we call that the ethmoid, sphenoid ethmoid recess. So this is a recess drain this posterior ethmoid and the sphenoid, the sinus. Now, if you see the blockage of the osteomiatal complex, you always looking at the possibility, mucosal thickening, sinus inflammation, anatomic variation, polyposis, or retention cyst, sometimes can be tumor, can block the osteomiatal complex. Now, osteomiatal complex, this is kind of like the years back, we went to the Italy, and there's the one of the area Capri has that nice a cave. When you go into that cave, you had to go through the hole under the sea. So it's which is reminded me kind of osteomiatal complex. If you block that one, you cannot come out, and or you cannot go in. So the sinus pathology, this is we have the actually it's very common if we do the dental implants. We have the viral infection or bacterial infection. The difference between the acute and the chronic is that the one acute sinusitis tends to see that the air fluid level, you can see it's kind of the air fluid level here, and the patient may have the cold or flu the symptoms, and sometimes you would see like air bubbles here. You see that the air bubbles here. Those are usually the acute sinusitis. For chronic sinusitis, you often see like a sclerotic change of the sinus wall. You see the opacification of the sinuses. Like this one, you see here, the sclerotic change of the sinus wall. And sometimes in the spring, in the allergy season, we often see that the polyposis here in the sinuses. Some people say it looks like a grape shape. So this is most likely due to allergy. And the other sinusitis, sometimes people may pay attention to, it's the fungal sinusitis. If the patient have the fungal sinusitis, and also if a patient have the immunocompromised condition, like HIV/AIDS, or sometimes the diabetes, they may have more severe the symptoms from the fungal sinusitis. That is, the fungal sinusitis can cause the bone destruction. So if you not recognize that the kind of sinusitis, when you place implant there, most likely that's going to be destroy the bony structure of that implants. Radiographically, a lot of time you may see the calcification inside, and like this one, you see some calcification in the maxillary sinus here, and the calcification of the sinus here. But not all the calcification are fungal sinusitis. Some other the inflammatory process also can have the calcification in the sinusitis. Fungal sinusitis is very often you see the calcification inside of the sinus. And the odontogenic sinusitis is very, very often as well. The apical lesion can cause the sinus inflammation, or sometimes that the odontogenic cyst also can involve in the maxillary sinus. Mucus retention cyst. This is normally the patient have no symptom, and also the floor of the sinus is intact and easy to recognize. The difference between the retention cyst and like radicular cyst or odontogenic cyst is that if the radicular cyst, you should be able to see like corticated border, like this one. Retention cyst, you don't see corticated border. Now, in the sinus area, if you see the destruction or nasal cavity area, when you see the destruction, they're almost like you see the two things. One is that the weakness granulomatosis. The other one is the malignancy. As a matter of fact, like if we see, you just see that the scan like this, combined CT like this one, my first impression, I probably will just consider the malignancy. I would not, but this biopsy turned out to be it's the weakness granulomatosis. And this is another the case with the bone destruction in the sinus, in the posterior aspect of the maxillary, the sinus here, and the tuberosity area as well, the bone destruction. And this patient turned out to be it's the squam cell, the neoplastic lesion in the posterior aspect of the maxilla. So the point here, if there's bone destruction, you have to rule out malignancy. And this is kind of unfortunate patient, this 16-year-old of the boy. And this one, certainly we did not expect the findings. You see that the bone destruction in the sphenoid sinus, and you can see here, the floor sphenoid sinus is destroyed with the soft tissue mass inside of the sinus. Looks like the the infection, but with this kind of bone destruction, most likely it's a neoplastic lesion. Because it's so young, we did not really suspect that this kind of the malignancy. But yeah, this is the one thing we have to really pay attention to, those with destruction of the sinus floor. Lastly, I would just give a little bit of background or share a little bit the information about radiation dose and the safety concern. Radiation, when here, like just the combing in the school, that's probably it's okay. We have radiologist guide, to use the the combing. But some the practitioner in United States in the early days, the people when they got machine, they said every endo patients, I'm just doing the combing now. Every orthodontic patient, I'm just doing the combing. So for the implants, the same thing. When do that implant, the pre-surgical assessment, use the combing. Right after implant, do another combing CT, and then the 3 months, 6 months, they follow up with the combing CT, because they have the combing machine in the office, dental office. So those kind of really cause that the concern, because the combing CT in general, radiation dose is still higher than the panoramic radiograph and the intraoral radiograph. So we have to consider this kind of the radiation safety. And some people arguing that they say, everybody say that the CBCT use less radiation than regular the CBCT, which is true. But if we're talking about medical CT, that's the radiation dose even much more higher. The combing, although it's not like medical CT, but still when compared intraoral, extraoral imaging is still also is significantly higher. And also that people was arguing, now you go to the airport, you have to go through the radiation. And if you go to the mountain, you get some radiation. When you go to the beach, you get the radiation. Why people to worry about radiation? So now the arguing is actually it's the really cannot compare. Sometimes we call the orange apple. It's not really, you cannot compare. Radiation, when we go to airport, like the radiation, the energy level cannot compare to the dental imaging X-ray photon. So we cannot really compare the two, the radiation, the dose. And we looking at the data in the United States, and in 93, the average per person received the radiation dose is 3.1 microsievert. But in 2006, you know that there's like 13 years difference. Each one received the radiation dose doubled. So now initially they say, okay, yeah, it's double. That's because the environmental, the global warming causing that people getting more radiation dose. But further the digging into it, actually it's not because of the global warming. It's because the diagnostic, the medical, the device produced the more the exposure to the population. If we look at the 1980s, so the medical exposure only count about the 15% of the radiation. Most of those radiations background, like it's from sky, from the ground, they receive the radiation. But 2006, that's the medicals contribute to like 48%. Now, further the digging into their contribution, you see the radon, this is a kind of from the ground, and the the CT contribute most, like 24%, and the other nuclear medicine, the 12%. Now, all these, they don't separate the dentistry from medicine. So our dental, the imaging is part of the medicine. So now the major contribution is like from that the CT. If looking at 93 to 2006, the annual increase procedure is the CT, about 10% increase. So that's probably the contributor to the radiation exposure increasement in the United States. And this is one of the study published in Lancet. This is actually the good study, and it shows radiation exposure from CT scan in childhood and subsequently risk of leukemia and brain tumor. And they found that if the childhood received medical CT, the younger than 22 years of age, so they have the higher the chance to get the leukemia and brain tumor. So this is shows the risk difference between the age. You can see the younger age, it's much more radiosensitive than older, the patients. You know, good thing for implants, it's most are in the older patients, but for orthodontic treatment, usually they are in the younger age, so that they are more radiosensitive than the adults. And the study based on the CT had the CT study. It shows that the children may be 2 to 10%, 10 times more sensitive to radiation than adults. That's why in US, we have like a movement imaging gently to the children. So that the radiation dose, the combined CT, often in the school, often people will ask, now, we know that the intraoral and the pan. So they said they will ask how many, when you take the combing, approximately how many like the panoramic radiographic dose. Certainly, we cannot exactly compare. Roughly, it's like 5 to 43 times of the panoramic radiograph. So the most these days, I think I would say like maybe 5 to 10 times. But the older, in the first generation, combined CT is about like 40 times, 43 times. That was a high, that the exposure. For medical CT is about 100, the panoramic imaging. So that's why for the implant study, some patients said that because the medical insurance cover me the medical CT, so they want to just get the insurance for the implant study. But I have to say that the radiation dose is much higher than combined CT. Probably should choose the combined CT instead of the medical CT. And to reduce that exposure, certainly you can have the different field of view. If you just do like endo, you can just have the small field of view, just 1 or 2 teeth can reduce the radiation exposure to your patient. And also the resolution for the implants, sometimes you don't need to have the highest resolution. You can use the standard or regular resolution. With the lower resolution, you also can reduce the radiation exposure to your patient. And sometimes you can get like a 70% reduction in those from the standard resolution versus the highest resolution. And some the company, some the CBCT machine, they have the faster like scan that also can help reduce the radiation exposure when compared to the high resolution scan. So that's some ways you can do to help your patients reduce field of view, reduce the radiation, the resolution to take the combined CT. Now, in summary, the CBCT has been widely used in our practice, diagnosis, implant, and also sleep apnea surgery. So pretty much every field are using the combined CT now. Certainly, maxillary sinuses are adjacent to the maxilla, so we often need to know the osteometer complex and other normal anatomy, and also the common pathosis abnormality in the sinuses. And finally, also we need to know the radiation dose and the safety concern. And if it is possible, you help reduce the radiation exposure to your patients. And so finally, I would also show some the school picture. I often shows that the classroom, the preclinical lab, clinic in the school, and also just before I came, we had a celebration 160 years. So we are one of the oldest dental school in the United States, actually second oldest dental school in the United States. So we have a lot of the history of the school. Thank you very much.
Thank you very much, Professor Yang, for the interesting presentations, also the invaluable insights on the importance of CBCT and sinus interpretation. Okay, ladies and gentlemen, next we'll proceed to the discussion section. And during this session, we encourage you to raise your hand if you have questions or comments that you would like to share. And also for the participant in the Zoom meetings, we conveniently have a way for you to ask a question. Just simply type your question in the Zoom chat and I will relay them to Professor Yang on your behalf. Okay, please, to the participants, if you have any question, just raise your hand. Okay, please. Okay, committee, could you do me a favor to give a microphone to the participant? Okay, please mention your name and then your question. Thank you.
Hello, Prof. Hello. Still working? Just speaking. Okay. Okay. Thank you for the opportunity, Prof. and Doctor. Thank you for your wonderful presentation. My name is Chivita. I'm from Oral Medicine Department. I like to ask about 2 questions. Is that okay? Okay. The first one, you already talked about the disease of the different department. One of is oral medicine about the diagnosis of squamous cell carcinoma. How about another lesion? Can we use the CBCT to diagnose about the oral lesion? And the second one, I read journal about soft tissue cone beam computed tomography atau ST-CBCT. Is any difference with the CBCT you already explained? Maybe about the radiation or the technique. Maybe you can explain about it. Thank you.
The other relations that can be diagnosed from the CBCT. Yes. Or from the oral medicine especially.
You mean the lesion from the oral medicine?
Yes.
Okay, very good question. For the oral medicine, certainly you're dealing a lot of lesions like TMJ or other like a pen, like the lesions. If anything related to the boning, if there's the boning lesion, you probably can use combined CT. Say if there's even the mucosal lesion, if the adjacent to the bone, if you some like oral cancer, squamous cell carcinoma adjacent to the bony structure causing the erosion, certainly we can use the cone beam to see. TMJ we can see, and this morning I was talking in the Congress there. In the future, we may have the dental MRI. The dental MRI will be particularly helping the oral medicine to see the mucosal lesion, soft tissue. But the cone beam for the soft tissue abnormality has a relative limitation. We cannot see the soft tissue with the cone beam. Although some of the company are working on it, trying to develop the soft tissue resolution, but that one it's not really in the clinical use yet. So if there is the possibility have the soft tissue resolution, that certainly can help with the oral medicine, the lesions, mucosal lesions for the diagnosis. But certainly the sinus issue and also that the TMJ issue, the cone beam can help you to make the diagnosis. What is the second question?
I'm sorry, I also missed the second question.
Oh,
Could you please repeat the second question? She read a journal about the soft tissue, cone beam, computed tomography, soft tissue CBCT. Have you ever experienced in using the soft tissue CBCT, or because the participant have ever read about it in a journal?
Yeah, so that's what I answer the portions. This is most study is going on. The multiple companies worldwide they are testing the soft tissue capability with the cone beam CT. The some of used like a dual image, the cone beam, so that but in the clinic, in the market, the machine is still on the hard tissue. The soft tissue is more like in the testing, or some maybe in early testing they published that the data, yeah, but not in the market at this point.
Okay, thank you very much, Professor Yang. Okay, Doctor, do you have any more questions or comments to Professor Yang? Okay, thank you very much. Okay, for the next question, is there anyone wants to ask a question to Professor Yang? Please just raise your hand.
Any question, actually. It's not necessary about this topic, yeah.
Okay, please.
Thank you. Thank you, Professor Jia. Such a fascinating presentation. As an oral medicine specialist, like my colleagues here, it's really intrigued me actually that especially on the first case that you showed us, it's about the ciliated cyst of, if I'm not mistaken.
Yes.
So you've mentioned that the diagnosis was oral squamous carcinoma. Is that also confirmed by the histopathology, or only confined with the CBCT is enough? I know you've mentioned that it's quite limited for mucosal lesion diagnosis, but somehow this case representing that. And second, perhaps concerning your last presentations, you've mentioned that the disease like brain tumors and etc. has been rising, affected by the number of radiation from CBCT. So as a radiographist expert, perhaps you could suggest us what are the procedures that we must use to limit the side effect of this CBCT? Thank you.
Okay, great. For the first question, that probably I showed the two cases. One, the surgical ciliation, the cyst. That one is the post-op medical surgery. So that one is not
So it's different from the
it's a
oral scan.
different.
Oh, I see.
Yeah. The second, the case with the shows the panoramic radiograph patient with the pain. They said the pain on the right side. That the patients with the squamous cell carcinoma. It's two different cases.
I see.
Yeah.
Okay.
Yeah. Now your last question is about that Lancet the study and for the childhood who exposed. That's not the combing CT. That's the medical CT. So when patients are younger than that, the 20 years of age, mainly it's like if it's in the early age receive that the medical CT, the chance, the percentage is instance is higher to have the brain tumor and the leukemia. That's the based on the medical CT data. We don't have that the combing CT data. The fortunate the combing CT, the radiation dose is less than medical CT. As I said, the medical CT roughly maybe 100 and the combing maybe most these days on the market is I have to say is a 5 to 10, the panoramic. So the radiation dose is much lower than the medical CT. But again, this doesn't mean that we can do the combing to every patient, every case. We still need to be mindful because there's that medical CT data shows there's the higher instance.
Okay, so there's no guarantee that CBCT is completely safe either.
That's actually, we put it this way, that no, we can say that no radiation is safe. Now, from the radiation protection purpose, that's why in US, probably in this country too, when you take the new patient, take the dental radiography, and we use the selection guidelines. The guidelines is when do you need to take a radiograph? Because in US, patients come in every 6 months or 1 year to regular checkup. So how often you can take the radiograph. We also have that the guidelines. The guidelines meaning is that if you find that this treatment or diagnostic procedure cannot be used other procedure, then this is justifiable. If you say, for example, you can do some of the testing, or you can use your eye to visit, you can see that lesion, then you're confident to make a diagnosis. You don't need a radiograph, then you don't take it. So it's kind of balance risk and benefit. So we can, a lot of time that the risk from the scientific the point, the risk they're not talking about one particular person. When you take a radiograph or then you will risk cancer, whatever. They're talking about the large population. They say, okay, when you take the full mouth radiograph, maybe on 1 million or 10 million, there's the 1% increase the risk. So from the public health, the prevention, so they just recommend that you have to be mindful. Radiation has potential, the risk. So it's not the same way, or we cannot doing that CBCT. But the one thing is for sure, we know that some doctor, they, for example, after implants, they do like 3 months, 6 months, those kind of follow-up probably is not necessary. Yeah.
Thank you very much for your answer, Professor.
You're welcome.
Thank you very much, Dr. Zakia. Okay, so we'll open for another participant who wants to ask any questions to Professor Yang. Or maybe we have question from the Zoom meeting chat committee. Okay. Okay, while we're waiting for the participant to prepare the question.
Okay.
Actually, I would like to ask you a question, Professor Yang. As what I see that sometimes that the lesions of the sinus lesions is found in the CBCT incidentally.
Mhm.
So it's not in purpose. So sometimes the lesion is found incidentally. And what do you think the most common lesion that are found in the sinus that actually cannot be observed by just seeing the panoramic imaging? Thank you.
Very good question. Yeah, the instant finding of the maxillary sinus is most often are the mucosal lesion, like sinusitis, mucositis. And when we take panoramic radiograph, sometimes we may see, sometimes we may not be able to see those kind of the findings. Good thing is like for this mucosal lesion or sometimes retention cyst or polyposis, if we just miss that kind of instant finding, usually the consequence is not that severe. But if there's some lesion, I was mentioned that with the bone destruction, those kind of neoplastic lesion, that kind of instant finding is a significant. So that's why we often in US we, since there's so many dentists or dental specialists have the combine the CT in their practice, so they would send those the scan when they do implants. Then just send the scan to the radiologist, let them look at, just make sure the cover all the liability, just to make sure there's no instant findings in the sinuses, in the skull base or middle ear or cervical spine. So just to prevent like a legal action in the future. And so for those instant findings, yeah, most are the inflammatory in nature, but occasionally you may see that the uncommon neoplastic the find, yeah, malignancies, yeah.
Okay, thank you very much, Professor Young, for the clear answer. And I would like to ask once again for the participant, if you have any question or comment that you would like to share, just raise your hand. Or do we have any question from the Zoom meeting?
Looks like it's a chat. Do they have?
Yeah, the Zoom chat. Nothing yet. And do we still have any time? Okay, okay, thank you. Please, the committee, please do me a favor to give the microphone to the Dr. Yeah, Dr. Arif. Okay.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Prof. Thanks for the presentation. Thanks for the chance for me to ask some question. Excuse me, Prof. So far we know the cancer has initial clinical like swelling and easy to bleeding, and for image they have a characteristic like angiogenesis. Maybe you have some picture in your combined city. Maybe you have experience about the angiogenesis, and you can conclude that is cancer. Thanks.
So you,
Okay, thank you.
maybe if you
Okay, let me try to clarify the questions. What the doctor means that if you sometimes if you find a cancerous lesions, you will see the angiogenesis and also that the lesion is easy to bleed. Maybe can you maybe in the CBCT can you also detect this lesion, the angiogenesis and also the bleeding, that you can conclude that this is a really cancerous lesions.
That's also the good question. So for the CT, the CBCT, we probably cannot see like, and that the we cannot see that like a tissue, but that's why that because that's the cancer lesion is still considered the soft tissue. The soft tissue is the resolution. It's not we cannot see on the cone beam. But again, that the new development for the dental MRI, hopefully dental MRI, we should be able to see that kind of the process. But that's certainly maybe in the 5-10 years in the future, we will have that kind of imaging modality to see.
Okay.
Do you
Okay,
have
Prof.
any
The point is the CBCT can detect the soft tissue and connective tissue maybe, Prof. Connective tissue also can detect in CBCT.
what about the connective tissue? Can we detect the cancerous lesions in connective tissue by using CBCTs?
The cartilage lesion,
The connective tissue.
connective tissue. The connective tissue lesions also that the soft tissue, the lesion. If the connective tissue involving the bone structure, causing the bone structure destruction, we may be able to see the bone destruction. And also we can see sometimes profile. If like, left and right, one side like tissue is kind of raised up, that's you can see there's some like a neoplastic in nature, but we cannot tell that the soft tissue, the lesion from cone beam in general.
Okay. Doctor, do you have any more questions?
Can we get a conclusion? The CBCT can detect soft tissue and connective tissue. What about MDCT? Can detect the soft tissue and connective tissue from MDCT, multidimensional?
Oh, yeah. For multi-detection of medical CT, yes. But for cone beam, unfortunately, it's no. Yeah.
Okay, thanks, Prof. Thanks so much.
Okay.
So, Professor Yang, actually CBCT is more advantageous to detect lesions in the bones, not in the tissue.
Yes. You know that the reason we the radiation dose is less than medical CT, because we use this cone-shaped beam. We actually reduce the significant radiation for the patients. But for medical CT, they do need to see the soft tissue, so they use the fan beam. It's very narrow beam, layer by layer, so they have the higher resolution. They can see that for the soft tissue. But we talking about the some study, they use the dual energy. Hopefully they can see the more soft tissue. But the current the CBCT on the market, they cannot see the soft tissue. Yeah. Okay.
Okay, thank you very much. And do we have any more questions? Or committee, do we still have any more time for questions? No more question. Professor Yang, I think we have already answered all the questions from the participants. And before we end today's session, do you have anything you would like to mention before we end this event?
Yeah, I would just thank you again for your invitation, and this is a quite honor. I'm so pleased to hear the second time in your school, and to speak with students, faculty, and this is the wonderful experience. And if there's any questions, yeah, please deliver to me. I would be happy to answer. The Lucy has my contact information. Yeah. Yeah.
We're sure gonna contact you if you have any question. Thank you very much, Professor Yang.
Thank you.
Okay, Once again, thank you very much for your invaluable insights on today's lecture, and also for the participant. Thank you very much for your presence and also engagement. And I think this is the end of today's lecture, and I will return the next session to the Nadine MC. Thank you.
Thank you, Professor Jie Yang, for the lecture. It was such an insightful lecture indeed. And thank you, Dr. Anggun Rafisa, for moderating the lecture today. Let's cheer for both Professor Jie Yang and Dr. Anggun Rafisa. As a mark of appreciation, Faculty of Dentistry Universitas Padjadjaran would like to give certificates and also gifts to both of you. I would now welcome our Vice Dean, Dr. Endang Syamsuddin, to hand the certificate and gifts to Professor Jie Yang and Dr. Anggun Rafisa. Doctor, you may went to the stage. And secondly, thank you once again, Professor Jie Yang and Dr. Anggun Rafisa. Everyone, this marks the end of our today's event. I hope you enjoyed and gained lots of benefits from this event. Before we end today's event, we're going to do some documentations. So please attend this on site and virtually on Zoom, especially on Zoom. You may now please open your camera and give your absolute best. And Dr. Jie Yang, you may come to the front of the stage. And Dr. Endang Syamsuddin. Still have one left. For the documentations, on the count of 3, 1, 2. Okay. Okay. Once again, on the count of 3, 1, 2. Okay. Thank you, Professor Jie Yang and doctors. Once again, thank you to honorable professors, doctors, and participants for attending today's event. Should there be any shortcomings in this event, please let us know and send us your feedback for future improvement. I'm Nadine Salsabila Surya. Good afternoon, stay healthy, and have a nice day ahead. Wassalamualaikum warahmatullahi wabarakatuh.
Welcome to the Faculty of Dentistry, Universitas Padjadjaran, with the concept of smart and green dentistry.